Hello, my name is David Trimberger, and this is attempt number 4 at peer-to-peer direct oral pediatric intubation. First thing that I want to do is gather up all my materials, such as a suction device, laryngoscope with a couple additional sized blades setting off to the side, my ET tube with a range of a 3.5 to a 4.5 set aside for pediatric patients, my BVM with a mask, an OPA, capnography, a stabilization device, and padding. First thing that I want to do is put on proper PPE. Going to come over to my patient, manually open the airway, inspect the airway for any secretions, vomitus, or blood. If there is, I will go ahead and suction. So I will hold down my suction for no longer than 10 seconds, zigzagging on my way out. Re-inspect the airway, see that it is clear. If it's clear, I'm going to take my OPA, properly measure, insert my OPA, going to connect my patient to a SpO2 monitor as well as a high flow nasal cannula. Going to connect my BVM to oxygen because my goal is I'm going to try and pre-oxygenate my patient and get their SpO2 to above 94%. My goal is 100 for a little bit, so that way whenever we go to intubate, they still have oxygen circulating through their system. So I'm going to also ventilate my patient at a rate of 10 to 12 times a minute, monitoring for adequate chest rise and fall. After I have set up my patient has been pre-oxygenated, I'm going to prepare for my intubation attempt. So I will remove my mask, connect my BVM to capnography, grab my stylet, remove my OPA, then I'm going to grab my padding, then I'm going to pad in between my patient's scapula to try and help put them in a better ear to sternal notch, put them in a better ear to sternal line. After I've done that, I'm going to displace the tongue, lift up, there we go. Insert my tube to the proper depth, inflate my cuff, remove my syringe, remove my stylet, connect my BVM to the monitor. Then I'm going to ventilate my patient for 10 to 12 times a minute, checking for adequate chest rise and fall, checking for that I'm getting proper capno, that I'm seeing some misting in the tube, and then I am also going to do a secondary confirmation by auscultating over both the lungs as well as the epigastrum to make sure that I have proper placement. Once I've done a secondary confirmation for proper placement and my patient has been stabilized a little bit, I'm going to go ahead and secure my tubing. Once I've secured my tubing, I will continue to, as I was doing all this, I'd be assessing for signs of hypoxia. I would be checking their SpO2, capnography, continue to ventilate at a rate of 10 to 12 times a minute and check for adequate chest rise and fall. And then I would monitor for any change in patient condition en route to hospital. Thank you.